So thank you so much, Dr. Malkowski, for joining me for today's Q&A. It kind of felt instinctive to set up this meeting and share some questions with you directly that we get asked frequently in clinical support here at Regenerus. So I'm definitely drawing on your expert knowledge and your experience. For those of you that are not aware, Dr. Malkowski is one of our fabulous speakers that are flying in straight to London, especially for our practitioners, for a wonderful 2-day doctor's data event called the Gut Hormone Masterclass on the 6th and 7th of June. The location will be central London. It's super easy to get to at Cavendish Square. Ticket prices are £225, and if you're a student, £180. You can book these tickets via Eventbrite. We will have sent out emails to all of you, and you can also book via our social media. Other speakers include Michael Ash, Benjamin Brown, and the wonderful Dr. Lylin Ferris from Doctors Data is also flying in. So for those practitioners that don't yet have their ticket, please book as soon as possible so you don't miss out. Well, on that note, let's get through as many of these questions as possible, Dr. Malkowski. No pressure. There's quite a few. Right, let me start with, when we think about the GI360, what really is the significance of the microbiome diversity score, and how should it be interpreted in conjunction with the dysbiosis index?
Yes, Paula, thank you so much. I'm happy to be here and discuss the GI360 today. That's a great question regarding the dysbiosis index and diversity score, because these are foundational components of the gut microbiome. And you can take a look at how these components of physiology are impacting your patient's not only GI health, but systemic health. So microbiome diversity is a very important aspect of any ecosystem, and the gut microbiome is no exception. This is a foundational component because it influences GI health, and it also influences systemic physiology. So gut microbiome diversity is associated with potentially efficacy of therapeutics such as probiotic. It can potentially be anti-inflammatory. We know that individuals that live in the blue zones maintain microbiome diversity into elder age, so it's potentially advantageous with regards to anti-aging. It's been associated with extroverted behaviors, colic, and so much more. So right now, if you look through the peer-reviewed literature, there are many studies associating gut microbiome diversity with positive health outcomes. So that's one matrix. The other biomarker is going to be dysbiosis. So microbiome dysbiosis, the inverse is true. You want a healthy, diverse gut, but you do not want your gut to be dysbiotic. The dysbiotic gut is a microbial signature that has deviated from a healthy, normal biotic reference range. And this has been studied in GI360 and peer-reviewed literature to be associated with obesity, diabetes, IBS, IBD. We're also seeing this with metabolic syndrome, and we have seen few studies with GI360 about autoimmunity. And so microbiome dysbiosis is one of these connections where we have this saying that all disease begins in the gut, and we have a connection here. And certainly chronic metabolic diseases do take root in the gut microbiome, and dysbiosis is a component of that.
That's fantastic. Thank you so much. When we think about other labs reporting different types of beneficial bacteria using PCR, how were the bacteria actually selected for the GI360 specifically?
Great question. So the bacteria for the GI360 were selected through a rigorous scientific process. So some concepts about the microbiome are that we could look at anything within the microbiome, the bacteria there, but GI360 specifically looked at conditions such as IBS, IBD, obesity, diabetes, autoimmunity, and they were able to discover the bacterial species that are associated with healthy individuals, and then the bacteria that were known in these conditions. And so that's how this microbiome dysbiosis signature was discovered, as well as elucidating the 300 bacterial species that can distinguish a healthy gut from an unhealthy gut. And so that is why we have these specific bacteria listed on the report. That shows us exactly that these bacteria are associated with health.
Yes. Okay. And so that feeds into understanding that certain bacteria have that peer-reviewed research behind them, and they're the ones that you focused on.
Exactly correct. There are over 50 studies utilizing GI360, and this has been studied in conditions such as IBS, IBD, obesity, diabetes, ankylosing spondylitis, scleroderma. So here you can see that this has been used in regards to really elucidating this healthy gut microbiome, and then conditions in which there is that dysbiotic gut microbiome. GI360 has also been published in studies uncovering the metabolic impact of medications like metformin, and to understand how the body and the gut microbiome plays a role in regards to therapeutics. So we will continue to learn more about this.
Yeah, this is obviously with certain medications, research will evolve with time with new prescriptions. So amazing. Why do doctors' data, we get asked this a lot, why do doctors' data not report on Methanobrevibacter smithii and D-sulfovibrio species?
Great question. So these bacteria were not shown to be influential in that research. So again, with that research, we started with over 1,500 bacteria and picked the key bacteria that implicate microbiome health with regards to abundance, diversity, and dysbiosis. And those bacteria were determined to not be significant, so they are not included.
Okay,
and again,
yeah, amazing. I think because they're so frequently within stool testing, people question it, but it completely makes sense if there's no research supporting their presence within stool testing in terms of that normobiotic, dysbiotic scenario, then
correct.
why would you put them there? Fantastic. Thank you.
Yes. Oh, sorry. I just want to say GI360, we don't tell you, what bacteria are there. We tell you about the bacteria that are associated with health and physiology. And so that's why we have this suite of bacteria. And we've done the research, like I said, over 50 peer-reviewed journal articles, thousands of patients have been included. And so you really know that when you have that GI360 report in hand, there's rigorous scientific evidence for the bacteria that are included.
Thank you. So, question around the functional markers that are positioned on that first page of the report. Do these functional markers include pathogens, or are they focused purely on beneficial bacteria?
Great points, Paula. And if you would be amenable, I can share my screen here to show this report here, the first page. Yeah. Can you see that report there?
I can see that, yeah. Right.
Okay. So the first section is that web there, and that includes the bacteria that we were talking about. So that is that focused over 300 bacterial species that is associated with abundance and diversity. So these bacteria we want in the human colon, but we want them in a certain value. And that's the same thing for the dysbiosis index and the diversity score. That is the same data subset. Then the next section we have is the GI health markers and then the key findings. The GI health markers, again, this is the information about the bacteria that we have been discussing that's well studied. And here we're looking at specific groups of bacteria that work together in functional guilds. So we're looking at specific bacteria that have a function, as example, that first line there, the butyrate producing bacteria. Those are generally healthy bacteria because you want butyrate producing bacteria, but then we do also have here the pro-inflammatory bacteria. So these are bacteria that we do want within the human colon, but we don't want too much of them. So that's a nuance and balance because the microbiome is really about balance and foundation. Now, the second section that we see there is the key findings. This is where you really will see pathogens identified. As in this report, we see C. difficile. So if there is a pathogenic bacteria, or if there is a virus or a parasite or yeast, it will be printed here as long as other actionable findings. In this case, we see some inflammatory markers and some stool chemistries. So that information is right on the first page there. Does that help to answer?
Yeah, no, that's great. Yeah, because it defines, to the bottom left, we've got this focus on profiling beneficial flora only. And then the rest of that bottom section on the first page is all about the rest of the report. That's what we're saying, isn't it? That there's pathogens and viruses that would flag there.
Absolutely. Yeah. So you can really, as the clinician, you can look at this first page and understand a snapshot of your patient's microbiome. And patients really do like this page as well because it's very user friendly. You can see, as we can see here, that things are printed and it's very understandable.
Thank you. This is interesting because the next question flags, why is microscopic yeast not reported on that initial summary page, on page 1? And why do sometimes we see microscopic yeast but no culture?
Yeah, that's a great question. So the primary look for yeast and the gold standard for yeast is going to be the yeast culture. That's really where you want to start. When yeast are cultured there, they are viable. And if they are dysbiotic, you can treat that. The second section that we have is a second check, and that's the yeast via microscopy. So this is where the expert microbiologist is looking under the microscope and they can see the cellular structure of yeast under the microscope. That yeast can be due to yeast that is associated with yeast that has been cultured, part of the life cycle. So some of it is alive and then some of it is dead. It could also be due to dietary yeast or environmental yeast, such as sourdough bread, brewer's yeast, wine, those food items, and then salad. Salad actually has a lot of yeast on it. And so you can see that there. You really want to understand your patient's history and presentation to understand what is occurring in those cases. One thing that Paula, I know you and I have discussed is that SIFO. So when there is fungal overgrowth in the small intestine and nothing in the large intestine, you may have a negative culture and a positive microscopy. Again, in this case, your patient would be symptomatic. So that would help to understand the findings on the report.
Great, thank you. That's really answered that with such clarity. And it is something that we're asked frequently in clinical support. So, okay, this is quite a big question. Can you describe the differences between PCR, microscopy, and microbiology? And what are the benefits of using these 3 different methodologies as opposed to using just one?
Absolutely. Great question. So as we mentioned, that culture is the gold standard for looking at yeast and bacteria. So culture enables the precise identification of cultured bacteria and yeast. This allows for the antimicrobial therapy via direct susceptibility that we will discuss later. So culture is still a very important aspect of understanding the gut microbiome. The newer technology on the block is PCR analysis. So PCR analysis detects the abundance and diversity of the key bacterial populations. We're looking for the DNA of the bacteria, and that is that first section of GI360. And so this helps us to understand the bacteria that are associated with dysbiosis and microbiome imbalances, as we will see with the dysbiosis index, diversity score, and for those GI health markers. So those 2 components actually really go well together. With the PCR analysis, we can understand a wide amount of bacteria that has been studied to understand dysbiosis and normobiotic reference ranges. And then we can pair that with the bacterial and fungal culturomics to understand the precise identification of bacteria and yeast that allows for the effective susceptibility testing and microbial therapeutics. So those portions go well together on GI360. These are both great aspects to understand the microbiome, and using them together really understands that we are not missing any portions
Yeah.
of this. And then the microscopy is another portion of GI360. So microscopy is the gold standard for parasitology. That is ova and parasitology, in which the expert parasitologist is looking under the microscope for the parasites and their eggs. That is still the gold standard test for parasitology, and that is included as well. The microbiologist or the parasitologist can also look under the microscope for other findings that we discussed, such as yeast.
Yeah, great. And I think the beauty of the three is they all complement each other. So one might miss something and the other might find it.
Absolutely.
So on a similar line, thinking about methodology, what are the advantages and disadvantages of using PCR, culture, microscopy versus, say, shotgun sequencing?
Yeah, great question. So shotgun metagenomic sequencing is the latest technology with regard to the microbiome. This is a technology that is excellent in a research setting. This generates large data sets, and there's really no established reference for the shotgun metagenomic sequencing as of now. So in a research setting, this is excellent to understand new information about the gut microbiome in research. Now, that is different than clinical practice. So in clinical practice, we want highly sensitive methods that are clinically relevant, such as PCR, culture, and microscopy. With shotgun metagenomic sequencing, this is looking at the genetic potential of the microbiome. So it doesn't tell us the function of the microbiome. When we're looking at PCR and culture and microscopy, this tells us exactly what is in the microbiome, and that information is reliable to make clinical decisions upon.
Thank you so much for clarifying that. So if we think about the GI360 and the inflammatory markers, the GI360 has three, which is quite unusual. So what is the advantage of that?
Absolutely. So having these three inflammatory markers is very helpful, because if your patient presents with GI symptomatology, we want to understand what is occurring there. And so we've been talking about the other considerations, such as dysbiosis or yeast, bacteria, pathogens. But the conditions that we do see commonly, IBS and IBD, these markers help to understand that. So lysozyme is the first marker. Lysozyme is associated with non-IBD inflammation. It could be associated with infections, and could be associated with IBS. Now, lactoferrin and calprotectin are highly sensitive for IBD because these markers are associated with enterocyte destruction. And so those are a byproduct of that pathophysiology. So these markers, calprotectin and lactoferrin, do help to elucidate IBD from IBS. Now, these markers, lactoferrin and calprotectin, are great biomarkers to understand disease progress and predict flare-ups, because their value is going to be associated with the pathophysiology, so the amount of enterocyte destruction. Now,
Right.
you can sometimes see lactoferrin and calprotectin with a significant infection, like a salmonella or something of that nature. So
it's, I guess, what we're saying is to refer back to the rest of the report. When the inflammatory markers are elevated, it could be a natural response to an enteropathogen, possibly. Mm-hmm. And then you've kind of got an answer as to why, but tracking, retesting is important for the inflammatory picture.
Exactly. So you would technically retest these in 4 weeks. And then if there's a positive finding second time, you'll retest again. And then you would refer for colonoscopy. At least in the States, that's the standard of care. So colonoscopy is the diagnosis for IBD. But then you can use these markers when you're working with your patient to monitor the treatment progress and remission and potential for a flare-up. And those markers, you will see those. They're very relevant markers in those cases.
Yeah, great. Thank you. Well, you've answered the next question. You beat me to it. So the next question was when should you retest if one of the markers is elevated? But the answer was 4 weeks.
Yes.
Great, thank you. So what is susceptibility and how is this actually helpful?
Great question. So those susceptibilities, when you have those for yeast and bacteria at the end of the report, those are actually performed at the laboratory on site. And what the microbiology department does is they will take that live isolated bacteria or yeast from your patient's sample, and they will put it directly in vitro in petri dishes with those agents. And that is a laboratory procedure to understand direct sensitivity in vitro of those isolated samples to these agents to guide treatment and targeted antimicrobial therapy. This helps you as the clinician, but this also helps doctors' data as part of our antimicrobial stewardship efforts. And so this actually helps to understand considerations such as antimicrobial resistance, right? We know that that is a global phenomenon, that these bacteria are becoming resistant to antimicrobials. And so this actually helps us to understand that. We do publish this data set every year on our website in an antibiogram.
Yeah, amazing. And I actually, with the report offering that, I think it's very interesting. Sometimes as a practitioner, you may have decided on a program, a protocol, and then you realize actually if you'd gone down that route, it wouldn't have been at all successful. So having the susceptibility there is an added bonus, a huge bonus for practitioners.
Yeah, absolutely. It's a perfect example and opportunity for individualized medicine.
Yeah, fantastic. So this does crop up with practitioners as a frequent question. When culture identifies a pathogen, dysbiotic bacteria or yeast overgrowth, is that susceptibility specific to that patient, or is it more of a generic overview?
It is specific to that patient. Exactly. Yep. Each sample is performed in the lab one at a time.
Yeah, brilliant. And just on that subject, why are doctors' data not able to check for susceptibility with all of the test findings?
Oh, that's a great point. So, with regards to that susceptibility testing, and we've been discussing, we need a live organism for that. So, when we culture the bacteria or the yeast from your patient's sample, that's a live organism. And the second step is then they take that organism and they put these antimicrobial agents in there. And they will actually see in the laboratory how it has killed the bacteria or yeast via standardized practices and protocols, such as the Kirby-Bauer method. Now, with other findings on the report, example, parasites. So this is a different test. For parasites, when that sample is collected in the vial, there is a preservative in there that kills the parasites immediately and preserves them so that when they arrive at the doctor's data laboratory, those expert parasitologists can look under the microscope and they can find the morphology to understand the exact identification of those parasites. And so those are already dead by the time that they're at the laboratory, so we cannot perform direct sensitivities to those. Another section of the report is going to be the pathogens panels. So we're looking for Salmonella and in the Giardia, those findings. That is via PCR. So those pathogens, the standard of care for those pathogens is going to be PCR testing because this is very sensitive and it's specific and it's very quick. So if you want to understand, does my patient have an acute infection, you're going to do PCR because it's very sensitive and it's very specific and it's very fast. If you wanted to see if your patient had, let's say, Salmonella, you can test that via PCR and get the results almost immediately versus if you needed a culture, these cultures are sometimes taking days to develop.
Right. Okay, fantastic. Thank you. So if we think about blood in stool, if red blood cells are identified, or occult blood is identified, what actually is the difference between the two?
Great question. So the red blood cells are active, visible blood. Occult blood is blood that has been hemolyzed, generally from the upper GI. So with the red blood cells, generally we're thinking hemorrhoids, fissures, or IBD. And then with the occult blood, this is coming from it could be from the lower GI, but it could also be from the upper GI, ulcers, polyps, those considerations. So they're two different markers.
Sure. Great, thank you. This is an interesting one because it's questioned, why is this on the report? And that's pollen. So what is the significance of having pollen on the GI360? And
Yeah, great.
I guess we look at that under microscopy, right?
Exactly, as you're mentioning, Paula. So polyps are seen under the microscope. They're generally considered artifacts, meaning they're not clinically significant, but they can be from food or the environment. Sometimes we see them with seasonal considerations or allergies. Now, these have historically been mistaken for parasitic eggs due to their size and similar shape. And so these expert parasitologists at Doctors Data are really able to understand the difference between the two and make a note of that on the report. So this is proper identification and ensures accurate interpretation of stool tests.
Thank you. That's great. So does PCR detect historical pathogenic bacteria even when there is no longer an active infection? And how do you evaluate whether the finding is a previous historical infection or a current infection?
Yeah, good question. So, as we're mentioning, PCR is very sensitive and specific. It identifies the genetic material, the DNA, or the RNA. So, the genetic material may be present in the absence of a live organism. So, when we're looking for PCRs by pathogens, that is the standard of care test because it's very sensitive and it's very specific. Now, if you have a case where the patient does not present with an active acute illness and there's a positive PCR finding, it may be due to a resolved infection or asymptomatic carrier status.
Right. Okay. That's really interesting. I know myself clinically, I have identified via PCR an historical infection with patients who actually have been so grateful to understand what that incident of acute illness was. So it really does have value in terms of current infection and historical infection. Thank you for that. So this is interesting regarding mucus. So when might we see mucus presenting in a stool test result?
Yeah, so mucus can be a normal part of the human colon, but you can see it in these samples excessively, especially in instances of inflammation or infection. So if there is a active infection, acute infection, we can see these. We also see them in conditions such as IBS and IBD. So that's very common. Sometimes if there is significant constipation or diarrhea, which may be present in some of these conditions as well.
Great, thank you. I know that that particular analyte is often confused for other aspects of gut health. And you mentioned previously about intervention with gut conditions can lead to what appears to be mucus in stool. And
Yeah.
actually, it isn't always.
Yes, unfortunately, some times individuals can mistake other findings for mucus. So sometimes it can be undigested food, it can be fibrous cast, it can be a supplement that appeared in that way. But the doctor's data sample is specific for that mucus that is going to be associated with the human colon. So we're able to delineate that.
Yeah, brilliant. Thank you. Why does the GI360 not include H. pylori and zonulin?
Yeah, so that's a good question. So H. pylori and Zonulin are available as affordable add-ons. So it's very simple to add those to the report if you'd like that information. H. pylori infection does not always require treatment, so that's why it's excluded from the report. Because in cases where the bacteria are colonizing but there's no symptoms, so it's not associated with active disease activity, then you wouldn't want to treat that. So that's why it's been excluded. As far as that goes, though, if you want to find out about that, you can simply add it on. And then same thing with the zonulin, it's available as an add-on. We do have some markers of intestinal bacteria that are associated with intestinal permeability. Of course, we're including Akkermansia eosinophila. That's a marker that's associated with mucosal barrier integrity and intestinal permeability. And in the GI health markers, we have these bacteria as well, these bacteria that are associated with the gut barrier protective mechanism. And that's a precursor to intestinal permeability.
Sure. Great. And also what's great about that is the profiling of those functional guilds at the beginning, that you can have a quick at a glance, oh, is the beneficial flora actually beneficial for my patient at the moment, or is it actively working to sort of encourage more risk of inflammation or more risk of intestinal permeability, which is exactly what you were saying.
Mm-hmm.
Last question, and it's a little bit of a grey area, I suppose, but practitioners do ask about SIBO and running stool tests. And there's often a query around, is there anything in the GI360 that may lead to the practitioner thinking about running a SIBO test? In your opinion, is that possible from the GI360?
That's a good question, Paula. As we are aware, GI360 is specific for the colon, so it's really not a marker for the small intestine. Of course, there can be some findings. So what we have noted is that when patients present with SIBO type symptoms, there are treatable findings or on the GI360, such as dysbiosis, diversity. So you can make clinical decisions based on the findings of GI360, whether it's some of those guilds that we talked about, the GI health markers are outside reference range, low actinobacteria, something like that. So you can potentially understand the patient's physiology from GI360, and that can potentially improve the symptoms.
Yeah, great. Thank you. I know that working with practitioners, this question comes up frequently, and there are ways over time of identifying certain markers trending in a certain way that you might consider, okay, with patient symptom presentation, is this a SIBO picture? But as you rightly say, this is an insight into the large colon, not the small. So thank you so much, Dr. Malkowski, for your input with this Q&A. It's been so invaluable, and we cannot wait for you to arrive in London on June the 6th and 7th and share your wisdom and clinical pearls with us further.
Absolutely. Thank you so much, Paula. It's always a pleasure, and I really look forward to discussing this further in June at the Gut Hormone Masterclass.
Thank you so much. Have a lovely evening.
Thank you.
Bye now. Bye.